So, good evening, warm greetings from Young India Intensivist. Before starting this academic session, I want to seek the blessings of Almighty to increase our knowledge, understanding, more so wisdom. Chest trauma, we are today going to speak about from one of very distinguished speakers. Chest trauma is the most common cause of death in people aged less than 40. And if we see the magnitude of the problem, 1.4 lakh people die of chest trauma every year. There is a lot of data, although there are evidence gaps, but we have some very good apex authorities like ATLS 11th edition, we have WSES, we have AES. Despite having clear-cut guideline documents, still the outcomes of chest trauma have not greatly improved in some time. There can be setup deficiencies, resource limitations, but one big part is gaps in knowledge, understanding, implementation, and collaboration. So I open this session to ma'am. Our today's speaker, ma'am is she's associate professor of critical care medicine at St. John's Medical College, Bangalore. Ma'am is DM in critical care medicine. She is also EDIC. Lot of other fellowships, awards, accolades to her credit. So, ma'am, frame is yours. So we may start the session.
Thank you for the introduction, Dr. Zahid. So yes, I'm going to be talking today about chest trauma, and it's a very important topic and something that we know that in trauma time is of the essence. So let's go ahead and get started with the discussion. Now, what are we discussing today? I'm going to start off with a small case that we came, not a small case actually. It was quite a complex case. I'm going to talk about the case a little bit and talk to you about the anatomy of the chest just a little bit. I want to stay focused on the clinical part, the mechanisms of trauma, a general approach to chest trauma, and of course the specifics of the management of what are known as the lethal six, little old terminology, and the hidden six. Now, there was a 26-year-old farmer who came to us from Madanapalli about 10 months back. He had suffered a bulgur injury while working, and he suffered a injury to his chest. There was no penetrating wound. It was a blunt trauma to the chest. He was brought to the emergency. In the emergency, what was noted that his heart rate was about 130 per minute. His blood pressure was 94/60. He was a little tachypneic. He was hypoxic. His chest compression was positive. Now, he was shifted quite surprisingly, quite quickly for an emergency CT. I'm saying surprisingly because the CT findings were quite severe. So I was quite surprised when I saw the CT that this man hadn't decompensated earlier. So what we saw is that he had a bilateral pneumothorax, what you can see here. Right side, we're seeing a pneumothorax. Left side, there's a pneumothorax with significant subcutaneous emphysema. So this is one of the examples or one of the consequences that we face in the emergency day in and day out and in the ICU when faced with a blunt trauma to the chest. Now, he underwent bilateral intercostal drain placement, and what you note here, there are two intercostal drains, one on the right side here and another one on the left side here. Now, along with that, what is the other thing that you can note in the X-ray is there's a small contusion here, a pulmonary contusion, and there are actually multiple rib fractures, which I don't think are very clearly visible here, but yeah, there are here. If you see closely, there's one rib fracture, one in here, rib fracture here, and rib fracture here. So multiple segments, multiple levels of fractures, what is also known as a radiological flail chest, which I will address in the coming slides. Now, this patient underwent, because of the multiple fractures, we anticipated that he had hypoxia, hypercarbia, and we anticipated that weaning may be difficult. So he was intubated and he underwent a flail chest fixation on day 4. Now, unfortunately, you would expect his primary pathology has been solved, his flail chest has been fixed. Okay, things are probably going to get better, but no, he had a stormy ICU course. He developed post-traumatic ARDS requiring multiple sessions of proning. He developed ventilator-associated pneumonia. We had a prolonged weaning period marked by multiple infections, complications like AKI, septic shock, multi-organ failure. Fortunately for him and us, We were able to he was tracheostomized, gradually weaned, and he was sent home after an ICU stay of almost 104 days and a hospital stay, I think, of almost 125 days. So long rehabilitation period, intensive post intensive care, pulmonary rehabilitation was required. So this is just an example of how what seems like initially a sort of straightforward case can evolve into something a lot more complicated in the ICU. Now, a little bit of anatomy. We know that the anterior chest, so there's some important landmarks that we need to know, anterior and posterior chest. So the anterior chest is from the sternal notch to the costal margin. Based on the movement of the diaphragm, the margins of the chest, based on inspiration, the depth of the inspiration and expiration, the margins of the chest can vary. We all know this, right? The inframammary fold is a very important landmark that we need to note, because especially in female patients, that is a better landmark to mark the fourth or the fifth intercostal space as compared to the internipple line. I'm saying this because this is the point where we perform any sort of emergency decompressive needle thoracostomy or a finger thoracotomy for patients who present with a tension pneumothorax, or a tube thoracostomy for either a pneumothorax or a hemothorax. So it's important to know this kind of surface anatomy. Now, another part of the surface anatomy is to know what is known as the cardiac box. Now, this cardiac box contains all the important vascular structures, the pulmonary hilum, the great vessels, and the heart itself, along with the diaphragm. And any penetrating injury to the cardiac box, which is marked by the area medial to the nipple line and below the clavicle, and and above, marked inferiorly by the costal margins. So, any injury here, especially any penetrating injury, has a potential to injure severe vital structures, such as the ones I mentioned. Now, what are the different mechanisms of chest trauma? There can be blunt trauma, penetrating trauma, a blast, or a crush injury. Now, any of these can result in rib fractures, flail chest, and open or a tension pneumothorax, hemothorax, pulmonary contusion, pericarditis. These are just some of the mechanisms in which the physiology will get altered. Now, all of this will essentially result in an alteration in the intrathoracic pressures. There can be lung collapse, results in hypoxia, hypercarbia, loss in the functional residual capacity, atelectasis, reduced tidal volumes. So hypercarbia, acidosis, hypotension, and then there is this vicious cycle of hypoxia, hypercarbia, acidosis, and hypotension. So unless the pathology is resolved quickly, the patient is going to rapidly deteriorate. Now, the initial approach for chest trauma is like any other trauma. So it's similar to the ATLS guidelines that we come across in trauma. There's the primary survey, secondary survey. We start off with a sample history. We check the vitals. Large bore IV has to be placed. Now, I will talk about specific things related to chest trauma. Now, coming to the airway. When we're talking about the airway specifically in chest trauma, there is a very high possibility of tracheobronchial injuries. Now, we need to watch out, or we need to have we need to be aware that, okay, this is possible, because during an emergency intubation, it is possible to exacerbate a pre-existing tracheobronchial injury. So if you're seeing the patient, if you feel that there's some crepitus around the neck, there's some subcutaneous emphysema, possibility of a tracheal rupture already exists. These injuries usually happen around 1 centimeter away from the carina, so which is where our endotracheal tube may pass. So in such a situation, and if it is possible, intubation under vision may be preferable. This is not always possible in an emergency, of course. Most of the times it is diagnosed subsequently by bronchoscopy. Almost 90% of the cases are diagnosed by bronchoscopy, or of course by CT imaging. We can diagnose these injuries. So airway can be a difficult airway. Always anticipate a difficult airway when managing a chest trauma. Next comes to breathing. When we look at the breathing, look, listen, and feel. I'll expand on this in the next slide, where what exactly we are looking for. Circulation, important in chest trauma to identify any open injuries. Sources of blood loss can be both obvious as well as occult, such as a hemothorax, send for cross-matching, lactates, base excess. These are basics of trauma. Now, disability. Now, in a chest trauma patient who has an altered sensorium could be because of an associated TBI. Always remember that. But it could also be because of the trauma itself, because it causes hypoxia, hypercarbia, acidosis, and of course hypotension, all of which can cause a reduction in the conscious state. exposure very important to identify any occult injuries. So so this is a little bit more about what we're looking at the chest when we talk about breathing or look, listen, and feel. As I said, examination of the neck is very, very important. A proper exposure. Look at the neck veins. Are they distended? Look at the tracheal position. Is there a deviation to any of the side, to a particular side? It could indicate either a pneumothorax or a hemothorax. Surface signs of injury such as bruising or laceration should be noted. Next, when we're looking at the chest itself, look for any symmetrical movement, signs of respiratory distress, listen for any diminished sounds, sucking sounds. So there can be in penetrating chest injuries, there can be a sucking sound which is seen through which air actually enters the chest actively with each breath. When we're feeling, we're looking at any tenderness, we're doing chest compression, we're looking at crepitus for subcutaneous emphysema, which may indicate a pneumothorax. Now, there are certain adjuncts. So this is basically about the basics of the examination portion. Now, we're going into the secondary survey and the adjuncts with ongoing resuscitation. So when you find a problem, we need to fix it. At the same time, we need to continue our evaluation. So ultrasound is something that is very, very common, pervasive these days in almost all emergency units and ICUs. So it's very important that every trainee learn how to do the EFAST, how to do a detailed chest ultrasound, and a transthoracic echo. TEE, of course, not everyone is not trained in TEE, but that's all right. At least an EFAST is a must. Along with that, chest X-ray. So these are recommended, especially in unstable, blunt, and penetrating trauma. Here, I'm just quoting guidelines from the WSES AAST guidelines, which came out quite recently in 2025, where it is said that ultrasound as well as chest X-ray are the level of evidence is moderate and the grade of recommendation is extremely strong. Now, contrast enhanced CT. Contrast enhanced CT may not have time for a CT in an unstable patient. You may not need it either. If you spot a tension pneumothorax, confirm it with the EFAST, go ahead and treat. There is no point in waiting for a CT scan. However, if the patient is stable, there are blunt trauma as well as...
Pardon, can I?
Yeah.
I'm getting a lot of messages. People are not able to join. Sahil, are you there? Everybody is saying that they are not able to join this. Okay, ma'am, you continue.
Okay, sure. Right. So the contrast enhanced CT, as I was saying, in an unstable patient, there may not be enough time, right? But stable patient with a blunt and penetrating trauma, the grade of recommendation is quite strong, with the level of evidence being moderate. Now, again, bronchoscopy is recommended when there is a suspicion of tracheal or bronchial injuries, which provides direct airway visualization. Now, how do we grade thoracic trauma? So there is a severity scoring system known as the thoracic trauma severity score, which uses 5 criteria. That is PaO2 by FiO2 ratio, the rib fracture, presence of a contusion, pleural involvement, and age. And all of this adds up. A value of a score between 13 and 25 actually is extremely predictive of a high risk of developing post-traumatic ARDS. Now, this age is a very important factor, is what we need to remember. The elderly, especially even with a single rib fracture, the morbidity in the elderly increases quite significantly. So, as compared to, say, a pediatric patient with the same level or a young adult, the elderly are much more susceptible. So, the severity of, so age is a very important factor and has a lot of weightage in thoracic trauma. Now, before I move on to specific aspects such as pneumothorax, hemothorax, one very important thing that I want to talk about, which a lot of times gets neglected a bit, is the pain management. Now, pain management is a very, very important part of managing trauma, and this has to begin right at the emergency itself, because the longer the patient is in pain, the more the sympathetic drive, shallow breathing, atelectasis, more hypoxia, more hypercarbia, and more chances of developing a pneumonia, hypostatic pneumonia, infectious pneumonias later on. So very important to give adequate pain relief right at the beginning. Now, this is just one of the hospitals. It's a protocol from one hospital, I think the Plymouth hospital somewhere in the United States. But this is just an example. The reason I've put this up here, you can find many protocols like this, is to draw attention to the multimodal aspect of the management. So it's not about one particular medicine. So we use paracetamol, we use opioids, we use non-steroidal anti-inflammatory drugs, and of course, one of the key things that we can do to alleviate pain is the use of regional anesthesia. Now, the level of analgesia that is used, or the kind of analgesia that is used, depends on the type of injury as well as the severity of the injury. The more severe the injury is, we may have to go higher on the level of analgesia, and a severe injury may require regional anesthesia. So what type of regional anesthesia? So if the fractures are anterior or lateral fractures, the patient is unable to sit or even roll, or the patient has a spinal fracture with a cervical collar, or is even morbidly obese, then a serratus anterior plain block can be given under ultrasound guidance. Posterior or lateral fractures can be managed with either an erector spinae block, serratus anterior block, or a paravertebral or an epidural. Now, bilateral fractures can also be managed with either bilateral paravertebral erector spinae serratus anterior blocks, or with the help of a thoracic epidural. So that was about pain management, and I just wanted that to talk about that in the beginning to draw attention to it, because it's something that we may miss. Now, coming to the deadly dozen. So the deadly dozen was actually used in, I think, the early 2000s to describe the kind of injuries that we are faced with in thoracic trauma. So these are known as the lethal six, and they're usually identified during the primary survey, that is airway obstruction, tension pneumothorax, cardiac tamponade, open pneumothorax, massive pneumothorax, and flail chest. Apart from this, what is usually identified in the second...
Ma'am, pardon to interrupt.
Yeah.
Can we? I have few queries, like based,
Yeah.
I can say, from audience standpoint. Like you said that up till here, that apparently patient was young and patient worsened, eventually took 4 months in ICU.
Yes.
So
Yes.
can we
Yes.
use some prediction scores for worsening, like shock index or trauma score for prediction of
Yeah. So
ARDS?
one I mentioned here was the thoracic trauma score.
Trauma severity
Thoracic
score.
trauma. Yeah, thoracic trauma
Severity score.
severity score. So this itself is predictive of ARDS. So a value
So
of the score.
what about more frequently used, like modified shock index and other?
See, shock, sure. I mean, you can use any other trauma scores can be used to this thing. I'm not 100% sure. I'll look it up and I'll get back to you exactly
And
which
and one more
score.
thing, ma'am. As per the newest ATLS 1, 2, 3, I like 11th edition. So before putting ABCDE, they put exsanguination as the first thing.
Yes.
Compressible external hemorrhage as the
Correct.
first thing.
Compressible. Correct. That's true.
That's one thing. So
Correct.
also you talked about the prediction of ARDS using this, which WSES document already has
Yes.
mentioned in their
Yes.
recent this prediction of ARDS. And one more
Yes.
query I'm having, that because once our patient is at bedside, so there is reluctance or division of opinion between surgeons and intensivists regarding the timing of rib fixation, and
Correct.
if we should go for that, and how should we steer? What does evidence say about
So
that?
I will come to that, because there is a section on flail chest
Oh,
itself.
okay. And one more thing on analgesia, is thoracic, like making it a routine putting epidural frequently. How is that in terms of evidence? Like,
I think so. The thing is, there is very good evidence to place a thoracic epidural, but at the same time, it also depends on your institutional capability also. You need to have someone who is, confident enough to place a thoracic epidural, especially in a trauma patient, where there are also other issues which are ongoing. There can be coagulopathy. The patient may be on anticoagulation. Sometimes the patient goes into ARDS, is on ECMO. So the regional anesthesia epidural, I find, at least clinically, like I find there's a lot more constraint. But regional anesthesia, like a plain block, a serratus anterior block, or something like that, may be actually a little more feasible.
I think this WSES document had mentioned that, like, we can't routinely recommend it for every case, but there
Correct.
may be cases who are not, controlled, where pain is not controlled or weaning is
Correct. It's
getting
basically when
difficult.
this, as I said, there is a grading system. So
Conditional
based on
recommendation
the
sort of.
severity of the, so it's basically the same kind of step ladder approach that we have in any type of pain management. You'll
Pain
start
management.
off with a lower level. You'll start off with oral analgesics, then you'll give paracetamol, you'll give a fentanyl opioid infusion, and then subsequently not able to control. Patient is, is finding difficulty in weaning. Tidal volumes are low. Patient is tachypneic, complaining of pain. Then you move to the next level, and eventually you will, have to probably try for thoracic epidural if everything, all the other factors are favorable.
And one more thing, the one of the X-ray slides you showed, I felt the left drain was like more going into apex. So
Yeah.
can you tell for our viewers if there are later they will see
I mean,
this
yeah, it's a little bit in the apex, but that's okay. We usually don't, if the lung is expanded, is well expanded, we usually don't reposition
reposition,
the
obviously?
drain. We usually don't reposition it because there's again risk of infection and all of that. So in this case, at least both the lungs seem to have expanded well. So I wouldn't worry too
Yeah.
much about it.
Okay, ma'am. Thank you, ma'am.
So sorry. Where were we? Yeah, so this is the step, this is the progressive approach that I was talking about. So you start off with the based on, so here what they've described is known as the stubble score. So this is a rib fracture score actually. They've used this to decide the level of analgesia that the patient should get. So based on the age, based on the level of hypoxia, based on the number of rib fractures, whether the patient is on anticoagulant, whether the patient has a chronic lung disease. So based on all of these, what they did is they gave a score, and based on that they decided what level of pain management would the patient require. So you to progress from here to here to here, if beyond paracetamol, if beyond opioids, if the patient still had moderate to severe pain on coughing, was not able to deep breathe, incentive spirometry was less than 15 ml per kg as it says here, or not able to comply with physio, then the next level of pain management was initiated. So it's always a step ladder kind of approach. Right. So, talking about the lethal 6 and the hidden 6. So, airway obstruction, tension pneumothorax, cardiac tamponade, open pneumothorax, massive hemothorax, and flail chest. These are known as the lethal 6. And the hidden 6, which are uncovered usually during a secondary survey, are these. That is the aortic disruption, tracheobronchial disruption, myocardial contusion, diaphragmatic tear, esophageal disruption, and a pulmonary contusion. Now, I'll be discussing most of the lethal 6 and a few of the hidden 6. Vascular injuries and myocardial contusion I have avoided commenting upon because I feel the talk is already really long, and they require a completely different sort of a segment altogether. Just touch and go is not really going to help much when it comes to those. Now, coming to pneumothorax. Pneumothorax, by definition, is quite simple: air between the visceral and the parietal pleura. Symptoms: dyspnea, chest pain, common symptoms. Signs. Now, when we're looking at pneumothorax, tracheal deviation on inspection is a very important sign if you're able to see it. The trachea deviates to the opposite side. These are things very basic. We already know. We look at asymmetrical chest movements. We look for tachypnea, respiratory distress, distended neck veins. Now, distended neck veins are more obvious only when there's a tension pneumothorax. Any open chest wound. Listen again for the sound, a distinct sucking sound which comes from these open chest wound. Listen for hyperresonance and absent breath sound on the affected side. Now, when we feel, what are we feeling for? We're feeling for crepitus. Again, you're confirming tracheal deviation, asymmetrical chest, and chest compression is positive. Patient is usually hypoxic, hypotension, and sometimes in altered mental state if these are severe. Imaging. On imaging, what do we see? Now, this is a simple pneumothorax, what we are seeing here, where there is a we are seeing absence of vascular markings, and we are seeing the lung border. This, however, is a tension. Here we see the mediastinal shift is not too much. The trachea is almost still in the center, a little bit to the right and almost in the center. But what we are seeing in this image is the trachea is completely deviated to the opposite side, complete absence of lung markings on this side. So this suggests a tension pneumothorax, which means there is a one-way valve which is allowing air to enter the pleural space, but it isn't allowing the air to exit. So eventually there is collapse and mediastinal shift. Now, the chest X-ray, however, is not very sensitive in supine position. The sensitivity is only about 28 to 75%, and there can be something known as an occult pneumothorax, which is a pneumothorax which is not visible on the chest X-ray, but it may be visible on a more advanced imaging, either CT or even ultrasound. Now, what is an open pneumothorax? Open pneumothorax is when there is a open injury or a penetrating injury within the chest wall. Now, if the diameter of this injury is more than 2/3 the diameter of the trachea, then air tends to enter the pleural cavity, right? And this creates a sort of sucking sound. So what this does is it equilibrates the pressures between the intrathoracic and the atmospheric pressures are equilibrated. As a result, the lung collapses. There is no more expansion which is going to occur, and there can be hypoxemia and hypercapnia. So the management for this is different. I'll come to it. Now, how does pneumothorax appear in an ultrasound? So I was talking about how ultrasound is a new modality and we need to use it extensively. So let's see how the pneumothorax appears. Second. So what we're seeing here is a normal lung, right? So we're seeing normal sliding, which occurs between the parietal and the visceral pleura at this level. This is what is known as the M mode. Now, I'm hoping that everyone knows a little bit of the basics of ultrasound. So this is what is known as the seashore sign, where we see the static lines of formed by the skin subcutaneous tissue. And this is the seashore effect caused by the movement of the pleura. Now, what happens when there is a pneumothorax? So when there is a pneumothorax, we see in comparison to this, there is no movement which is occurring between the parietal and the visceral pleura. So this is static. And when the M mode is used at this level, what we see is the barcode sign. So the whole, this typical seashore appearance is absent, and there are only straight lines which are visible. So this is a very sensitive marker for a pneumothorax. It may not be very specific. Now, the reason I say this is because even endobronchial intubation can cause an absence of ventilation. Essentially, what it is, when there isn't movement between the visceral and the parietal pleura, that could also happen because that particular segment of the lung is not getting ventilated, which could also happen, as I said, in an endobronchial intubation. So while it is sensitive, it may not be very specific, right? But it is definitely more sensitive. And in tension pneumothorax, when you don't have time for a chest X-ray, CT, you already have a very strong clinical suspicion. When you see something like this, there is, enough evidence for you to go ahead and do a decompression. Now, a more specific sign is something known as a lung point. So what you see here, these vertical lines are known as B lines. I'm hoping everyone's familiar with the term. Now, when we look at this image, what we see is the lung is moving. This portion of the lung is moving. We're seeing B lines. However, this portion of the lung is static and there are no B lines. Now, there is actually a point of transition between this and this. The portion of the lung which is moving and the portion of the lung which is not moving. And this is known as the lung point. So, if I place the M mode at this particular point, then what we're going to see is on one side, we see the barcode sign, and on one side we see the seashore sign. So this is known as the lung point, and it is highly specific. Now, it's not very easy to elicit. It's not always easy to elicit it. It's not always present, but when it is there, it is extremely specific for a pneumothorax. Remember, ultrasound may not be useful if there is subcutaneous emphysema, and it can be less accurate in extremely obese patients where the visibility may be compromised. Now, if this is the same CT I showed you earlier, now if I have to elicit lung point in this patient, my probe should be somewhere here, right, on the CT image. So this is where the probe will be if I have to elicit the lung point. Now, how do we treat it? We spoke about the imaging and the presentation and the imaging. Now, the treatment in an emergent condition, there are two locations where decompression can be done. One is the second intercostal space in the mid-clavicular line. And then, of course, there is the fifth intercostal space in the anterior axillary line. Now, these are the two locations for finger thoracostomy as well as needle thoracostomy. Needle thoracostomy is usually done with a 14 gauge or a 16 gauge needle or a catheter. A needle is placed and a catheter can be threaded through the needle itself and left in place. The issue with doing this is that it's a temporary fix. The catheter can kink, it can get obstructed by blood or tissue. So the pneumothorax, especially if it's tension pneumothorax, may reappear. In an emergency, if you don't have anything else and the pneumothorax is very large, patient is collapsing, then a simple finger thoracostomy is possible, where through the fifth intercostal space, a blunt dissection is done, and you penetrate through the into the pleural space and allow the air to be released. Again, this also the tissue can it's not a permanent fix. The tissue can go block the opening and the pneumothorax may reform. So this is just a temporary procedure till a definitive procedure, that is tube thoracostomy, is done. Tube thoracostomy again is done in the fourth or the fifth intercostal space. We usually do it by blunt dissection using a Kelly clamp and threading a intercostal drain over it. Now, what size of drain do we use? Usually 14 French drain is sufficient for the pneumothorax. If you're suspecting an associated hemothorax, a larger size drain may be necessary, but usually even for a tension pneumothorax, a 14 French drain is sufficient. Next, do we use suction or no? Now, the evidence seems to be a little contradictory. Clinically, in some situations, we have used suction, especially when the lung is collapsed and, it is even after the tube is placed, we rule out other injuries, but the lung is not expanding. But there isn't very overwhelming evidence to say there is a mortality benefit. There is some evidence to say that there can be some reduction in hospital stay and duration of chest tube insertion, but nothing very great. So suction, again, you have to decide from situation to situation, case by case basis, whether it needs to be used or not. Now, open pneumothorax. The treatment for this differs a little bit. The first step is to cover the open wound with a three-sided dressing. So this is to prevent tension physiology, because if the wound is completely closed, then that will cause that there is no way for the air to exit. So immediately that's going to convert the open pneumothorax into a tension pneumothorax. So by placing a three-sided dressing, what we're doing is during inspiration, the dressing is sucked over the wound, and by doing that, the opening is sealed, and during exhalation, the air exits through the opening. That is because the pressure is released. So that is the first step. Definitive is a tube thoracostomy has to be done at a separate site, not through the wound itself. It has to be done at a separate site. Patient will need a surgical exploration of the wound and closure. A 14 French drain here again is sufficient, and this patient will need antibiotic prophylaxis. Now, occult pneumothorax. What do? We see this quite a lot, actually. There is no pneumothorax on the X-ray, and then somebody does a CT and there's one tiny pneumothorax sitting there. Patient is on oxygen. You're wondering, what do I do? Should I place an ICD or not? Now, this happens in almost 2 to 15% of trauma populations. If the patient is asymptomatic and if the distance is less than 3.5 centimeters from the chest wall in the CT, then a tube thoracostomy is not necessary. However, if there is a serial increase in size of the pneumothorax on chest X-ray, patient is in need for aerial transfer, where there's a possibility the pressures may drop and the pneumothorax may expand. In these cases, you may need to place a tube. If the patient has had severe chest trauma, concurrent hemothorax, and especially if the patient requires positive pressure ventilation, either non-invasive or invasive, then there is a likelihood that the patient will require a tube thoracostomy later on. But if the patient is not, if these risk factors do not exist, then likely you may get away without placing a intercostal drain for this patient. Now, I've shown you this image. I think we're lacking in audience, but yeah, so what could be wrong here? Dr. Zahid we can discuss it amongst ourselves. You're not visible. You're not audible.
I'm not getting it very properly, but I can feel there is some rim of something is differentiating. Either it's collapsed part of it, and then there is rim on
So
the
essentially
outer side.
here there's a pneumothorax and we've placed the intercostal drain, but the lung is not
It's not.
completely expanded. right? So we're seeing there's still a lung border here, and there's the intercostal drain here, and there's still absence of lung markings here. So this could be for multiple reasons. One, sometimes there can be a mucus plugging of the bronchus, which may prevent the lung from mucus or even blood, anything blocking the
Right.
bronchus, and it may prevent the lung from expanding. It could be, as I mentioned before, tracheobronchial injury causing a persistent air leak. So because of that, the lung may not expand. Sometimes the tube itself could be blocked. The thoracotomy tube itself, the thoracostomy tube itself may be blocked. We may need to either change the tube or relieve it using a milker or something like that. So this is just something to think about. I'll show this image again later on. Next, coming to hemothorax. Hemothorax is
Ma'am,
essentially a blood. Yeah,
two things about this
yeah, yeah.
pneumothorax part. You told one very important thing about occult pneumothorax.
Yeah,
Lot many times straightforward. I have patient on oxygen. Now I am planning
correct.
mechanical ventilation. So many a times they tell me that the moment you put patient on positive pressure ventilation, it may worsen. So put a drain. I
Correct.
have seen different way. Even I have a kid lying in my ICU right now. So basically, we could do CT after placing tube. Patient
Hmm.
was overnight ventilated. A bit patient became better. We don't have
Hmm.
bedside CT. Then I shifted patient. Patient is already on mechanical ventilation, like for 24 hours, more than that. And there is
Correct.
very small rim of pneumothorax at that time.
Correct.
Now airway pressures are not increasing. I don't see any signs. But then I think that am I clear on these things? If you were at my place, ma'am, I just want your wisdom, like how you would do
So,
at this point.
as you said, the finding is more incidental, right?
Yeah, yeah,
It wasn't even detected clinically. So, in that situation, I would wait, but it would be
great.
part of my constant assessment.
Yeah,
Your threshold for reevaluation or reassessment becomes very low. So, you're constantly going to be looking at the airway pressures. Any change in the peak pressures, you are going to immediately reevaluate. Repeat lung ultrasound probably more frequently. I would say if you have the manpower with the expertise to detect a worsening in time and to place a tube in time, then it's fine, it's safe. The question is, are we safe? That's all it is. So if
that's
you
right.
have round the clock manpower who can detect a worsening, act on it in time, and prevent any catastrophe, then please, definitely you can wait on it. That's what I would say. It's a more
Okay,
practical
ma'am.
answer.
Yes, definitely. I agree with the same. And second thing is, ma'am, if I imagine a situation, for example, I am working in one of the peripheral hospitals in India, and I receive a person who is having pneumothorax. I can clinically feel. I don't have X-ray. We agree on this thing that ultrasound is coming in a big way. Now I don't
Hmm.
have imaging, neither ultrasound, neither I don't have. I'm not having X-ray. Now I see patient is in shock. I can feel clinically whatever the signs from Creptus, hyperresonance on one side or whatever. Can I go for ICD placement directly without imaging in that situation?
I mean, I think so. I think we must. I don't think there is an option in that kind of a situation. Patient is crashing. Clinically, it is obvious, that the patient has a pneumothorax. What option do you have? If you don't treat it, he's anyway going to die. So you would just speak openly to the family. Tell them these are the constraints we have. If you have time, then take a proper consent from them saying that this is what we're suspecting. Unfortunately, we don't have these facilities here, but you're acting in good faith, and you openly tell them that this is what we're going to do. These are the possible complications. It may bleed, it may enter the diaphragm, it may enter the lung. But we have to do it right now, because if we don't, then the patient is going to crash. So
Okay.
I would say yes, please go ahead. In fact, I think a lot of TV shows have made a routine of placing ICDs in airports and planes and all that. It's become a thing of heroism to do it on most of these medical TV shows also.
Thank you.
Actually, the people are very receptive to it. Like they know that this can happen. I mean, at least the urban population. Anyway,
Yes.
okay. Going ahead, hemothorax. So the blood in the pleural space is basically what a hemothorax is. Now you will see that the signs and symptoms are very similar to that of a pneumothorax. in terms of clinical assessment. Only thing is the resonance is reduced, but of course, I'm not going to, sit and do percussion on the patient, but it's just a more theoretical discussion. But everything else is very, very similar. You may get distended neck veins only in case of a massive hemothorax. Otherwise, actually, if the shock is severe, there's blood loss which has happened, then the neck veins actually may be collapsed if the intravascular volume is low. Hypoxia, hypotension, altered mental status, all part of the presentation. Now, here I'll talk a little bit more about EFAST. It's used for the evaluation of both hemothorax, almost all, any form of chest trauma. EFAST is essential, where we basically look at 5 main areas: the subxiphoid, the right upper quadrant, the left upper quadrant, the pelvic, as well as the right and left anterior chest. So what are we trying to rule out? We're trying to look at any solid organ injuries, the liver, the spleen, looking at any free fluid in the abdomen. We're trying to rule out any form of hemothorax. So that's where we're looking at in the right upper lower quadrant, where we can see the liver as well as the Plapp's point on both the side, and the spleen and the Plapp's point on the left side. Anteriorly, right and left anterior chest, we're looking at ruling out pneumothorax. The subxiphoid area that we scan, we're specifically looking at any pericardial tamponade, any free fluid around in the pericardial space. So specifically, we can look for that. So this is basically a comprehensive survey. Ultrasound is the linear probe, especially which is around 5 to 10 megahertz, is almost 98% sensitive and 100% specific in detecting free fluid in the pleural space. So it can be extremely, extremely reliable in a hemothorax. Now, what are the limitations? As I already mentioned, morbid obesity, subcutaneous air, in the pneumothorax, there may be subcutaneous emphysema. Retroperitoneal pelvic bleeds are not visible on ultrasound. If the bleed is extremely slow or the patient has rebled, it may need repeated imaging. So one EFAST may not be enough. You may need to repeat it after half an hour, 1 hour, or 2 hours, either based on your clinical judgment, or if the patient deteriorates, immediately we need to repeat an assessment. Again, it's operator dependent. It requires a little bit of training, not too much, but a little bit of training is enough. A lot of false positives can happen. Endobronchial intubation, pulmonary adhesions can all mimic a pneumothorax. Now, the chest X here, what we're seeing is a massive hemothorax in this X-ray here. So it's quite obvious. But chest X-ray requires almost around 300 ml of blood for adequate detection on the chest radiograph. So it's not very sensitive. This X-ray here, I'm trying to show is a air fluid level. So this is a hydropneumothorax, combination of both air and blood in the chest. So compared to that, ultrasound is much more sensitive, as I already mentioned. So 97.5% versus 92.5% in chest X-ray. It's also faster. An ultrasound would take only about 1.3 minutes, whereas in chest X-ray would probably take around 14 to 15 minutes to complete. So fluid in a ultrasound, I'm hoping people are familiar, but usually we see a quad sign, we see a jellyfish sign, you see a part of the collapsed lung. And if it's a hemothorax, we also see within the fluid here, we see hyperechoic regions if it's a hemothorax. Now, CT can also be used. If it's a unstable patient, you may not have time to do a CT. You may have to place a tube thoracostomy or take the patient to the OT directly. But if time permits, then of course CT with contrast especially could help to identify any area of bleeding, any associated vascular injuries, any associated airway, tracheal, bronchial injuries can be identified. In this particular imaging, what we are seeing is hemothorax, but the lung is collapsed. So if you see this image here, we see that there is this is a scout of the previous image itself. So we're seeing there's a hemothorax, but there is no shift of the diaphragm to the opposite side. That's because the underlying lung is actually collapsed because of some mucus plugging. So the shift is to the same side. So same side lung collapse because of mucus plugging along with the hemothorax. Now, a contrast-enhanced CT can also be used, as I mentioned before. This is a right hemopneumothorax on a CT. Now, coming to the treatment. So, the treatment aspect, if the patient is clinically unstable, approach according to the ATLS guidelines is for a urgent thoracotomy. If you have placed a drain, if the initial drainage itself is more than 1500 ml or it is more than 200 ml per hour for 3 hours, that is an indication for a thoracotomy. Other indications for thoracotomy are if there's a large unevacuated clotted hemothorax, VATS can be done. If the patient is somewhat stable, developing cardiac tamponade, these are the other associated indications for thoracotomy. The patient has a chest wall defect, massive air leak, vessel injuries, esophageal injury, diaphragmatic injury, or a cardiac injury. Now, if the patient is clinically stable, then initial labs can be sent, EFAST, CT thorax can be done. Now, if the pleural effusion is estimated at more than 300 ml, bloody pleural effusion or hemothorax, then drainage can be done. Once drainage is done, if the patient again is unstable, then patient goes back to thoracotomy. VATS can be done, but still a thoracotomy is preferred. If the patient is stable, but the hemothorax is, not as bad as, requiring emergency surgery, but it is retained, it is still present. You placed a tube, you're not able to drain it out, then you still may need to do a surgical procedure to drain out the hemothorax. I'll talk more about that later on. If the collection of blood is minimal, that is less than 300 ml, then nothing to be done. Analgesic therapy for pain and monitoring should be sufficient. Now, when is VATS indicated? In patients who are respiratory and circulatory systems who are stable or they subsequently stabilized. If there is stable penetrating chest trauma, then it can be used for diagnostic as well as therapeutic purposes. Even in presence of intrathoracic hemorrhage, if there is no compelling reason for thoracotomy or vascular intervention on CT, then VATS can be done. If there's a relevant retained hemothorax that is more than equal to 300 ml, then it is actually recommended to do an early VATS, especially within the first 4 days after trauma, to reduce the risk of complications like empyema or trapped lung later on. A rib fracture with a retained hemothorax or suspected relevant associated injuries, synchronous VATS can also be done along with the flail chest fixation, that is the osteosynthesis. Fibrinolytic therapy is another. I'll just come to retained hemothorax in the next slide. But VATS is considered superior to fibrinolytic therapy in a retained hemothorax. So I'm saying retained hemothorax again and again. What is that? The retained hemothorax is basically any sort of collection that remains behind after a tube thoracostomy is done to drain the hemothorax. Now, it's basically if the blood remains, it can get infected. There can be pneumonia, there can be empyema, or there can be a fibrothorax which results. Irrespective of size of the drainage tube, the incidence is almost 11 to 29%. Now, thoracotomy, tube thoracostomy for hemothorax, the size of the tube that is recommended is usually 28 to 32 French. Evidence has shown that more than 32 French is usually not beneficial. There is no additional benefit of using more than that. Now, use of suction may be helpful to reduce the incidence of retained hemothorax. The other technique that has been described is a saline lavage. That is, if the patient is stable, then while the intercostal drain is placed or while the tube thoracostomy is done, a catheter is passed and a warm saline lavage is done to drain the blood which has been accumulated. Now, if despite all of this, if retained hemothorax happens, then early VATS is indicated. Now, fibrinolytic therapy with streptokinase has been done in the past, and it can still be done. When would you consider fibrinolytic therapy? If your patient is frail, elderly, not fit for a big surgery or VATS, then fibrinolytic therapy can be attempted for a retained hemothorax. Now, coming to flail chest. Definition, diagnosis. The definition is radiological, the diagnosis is clinical. So basically, it's basically defined as more than 2 broken ribs in more than 2 places as visualized on any imaging study. So here we see that the rib fracture is here, 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 here. So more than two places, and more than or equal to two places, more than or equal to two ribs. Clinical flail chest is when we see the paradoxical movement. That is when there is inward movement during inspiration and outward movement during expiration. So this sort of paradoxical movement of the flail segment during respiration is the definition of clinical flail chest. Now, as I said, it's a clinical diagnosis characterized by pain, paradoxical movement, and tenderness. CT is required to rule out associated pneumothorax, hemothorax, and underlying lung contusion. Flail chest is more obvious if the patient is spontaneously breathing. The presence of positive pressure ventilation may actually mask the existence of a flail segment. And then subsequently, when you start weaning the patient, then the flail segment may become more obvious. Now, management, mainstays, pain management and pulmonary hygiene. It's important to promote alveolar expansion with chest physio and incentive spirometry. What are the indications for surgical stabilization? Now, there are very specific indications. What they say is all hemodynamically stable patients presenting with a flail chest actually should undergo surgical stabilization. More so if there are multiple rib fractures, that is more than or equal to 3 in the 3rd to 10th ribs. If they're ipsilateral, severely displaced, and/or in presence of a poor response to or impossibility to wean from mechanical ventilation. So our patient also had a flail chest. It was actually fixed quite early itself on day 4. Despite this, we had a lot of difficulty weaning him. So in the absence, I would think it would be a lot harder. So when it's difficulty, especially when faced with difficulty to wean, it's very important to fix the flail segment. Severe pain, which is unresponsive to other treatments, is another indication for surgical stabilization. When is it done? Ideally, they say, within 48 to 72 hours, if contraindicated. Now, the absolute contraindication is only hemodynamic instability. That is the only absolute contraindication what I came across. Almost everything else, either traumatic brain injury, morbidity in terms of some form of cancer, anything else, they're all just relative contraindications. But an absolute contraindication is only hemodynamic instability. So in this situation, it can still be done within 3 to 7 days is what is recommended. So this is our patient who underwent fixation of the flail chest. Now coming to pulmonary contusion. Now, pulmonary contusion is basically when the blunt trauma of the chest, it doesn't cause an alveolar injury, but it causes vessel injury. So there is no tear in the lung tissue, but the capillaries get injured. There's alveolar damage. There is leakage of blood, fluid accumulation within the alveoli, and there is a loss of FRC which occurs. There is a loss of tidal volume. There's a intrapulmonary shunt which is formed, resulting in a ventilation perfusion mismatch, loss of lung compliance, hypoxia, hypercarbia. These are all the consequences. Now, the size, severity, and clinical impact is not visible at the outset itself. It can keep getting worse, and it especially gets worse within the first 72 hours. And what we see is clinically, it peaks at 72 hours. Now, the signs and symptoms of pulmonary contusion, the patient may be initially asymptomatic, subsequently may develop dyspnea, tachypnea, wheezing, cough, or even blood streak sputum, and the distress usually peaks, as I said, at 72 hours. Otherwise, there are no other signs of trauma unless there are other injuries. The trachea is central, patient may have distress, some amount of cyanosis, chest movement is largely symmetrical, there may be some amount of rales, trachea is central, patient may be hypoxic, hypercapnic, and have an alternate mental status. Now, this is imaging here. What we see is it's basically a sort of hazy ground glass opacification, which is non-segmental, is typical. And usually on X-ray, it appears after about 6 hours. It may appear early on CT. So this is basically the pulmonary contusion, what we are seeing in this patient. Now, management. Management is mostly supportive, lung protective ventilation, avoid over-resuscitation because the capillaries are already leaky. Excessive fluid can cause worsening oxygenation in ARDS. Pain control, again, very important. And pulmonary hygiene, pulmonary toileting is very, very important here. Next, coming to tracheobronchial injury. This is a injury which is a very high mortality. Patient usually presents with obstructed airway, signs of obstructed airway, respiratory distress, hypoxia. They may have hemoptysis, cervical subcutaneous air may be present. This is the same image, persistent air leak after a tube thoracostomy and incomplete lung expansion. Again, it's diagnosed usually by bronchoscopy. CT is an adjunctive tool which can be used. Treatment, airway management, as I said, if you're already suspecting a tracheobronchial injury, under vision would be preferred, but again, that's not always possible. If possible, please do it under vision. One lung ventilation may be required if the injury is very, very severe. Large injuries may need early surgical repair, and especially if they're large, within 24 hours, the repair may be necessary. Next, coming to another important injury that we see in trauma, and that is cardiac tamponade. Now, cardiac tamponade is essentially the buildup of blood within the pericardial space. So, when the blood builds up, what happens? There is a decreased propensity for the atria and the ventricles to relax. The ventricles don't relax. There is increased diastolic dysfunction. So, because of the diastolic dysfunction, and there is increase in the right atrial pressure. So there is also increase in the intracardiac pressures. So because of that, there is reduction in the venous return. Because of the reduction in the venous return, there is a subsequent reduction in the stroke volume. All this happens because the ventricles don't relax, so the ventricles don't fill. So because they don't fill, the stroke volume also reduces. So the positive intracardiac pressures and as well as the reduced venous return cause this. And I would think the diastolic dysfunction would also exacerbate or also reduce coronary perfusion. Now, symptoms, usually patient presents with dyspnea, tachypnea, chest pain, altered mental state may be present. The trachea is central. Here, one of the very important clinical signs is distended neck veins. On auscultation, the heart sounds are usually muffled. All of us are familiar with the Beck's triad. There is hypotension, muffled heart sounds, and the distended neck veins. And clinically, you may also palpate a pulsus paradoxus. On ECG, low voltage ECG is possible, as well as electrical alternance, which is not a very common feature. Actually, the most common feature is just sinus tachycardia on ECG for a pericardial tamponade. So cardiac tamponade, this is the Beck's triad. Now, imaging. So imaging is again very, very important here. If you have echo probe with you, you're doing an EFAST, then it's possible to identify the blood in the pericardial space. So the earliest sign that there is there may be blood in the pericardial space, but is it tamponade? So how do we identify tamponade physiology? So these are some of the signs of tamponade. The earliest sign is the collapse of the right atrium during systole, that is RA, systolic collapse. What we are seeing here is a subxiphoid view. So in the subxiphoid view, we can see that there is fluid accumulation, and if the RA is collapsing during systole, then that is an indication. A plethoric IVC, that is, it's not collapsing, less than 50% collapse. The IVC itself is more than 2.1 centimeters in size. This is another indication of the tamponade physiology. Then, of course, the right ventricular diastolic collapse. Again, this is significant collapse, and this is the parasternal long axis view that we are seeing over here. And again, in the four-chamber view, this is a little harder to elicit, but if we are able to get the flow across the mitral valve, then it is possible to see a variation in the E and the A waves. Again, this is a little too much. It's not mandatory to know this, but at the same time, if you know it, then it is useful. So variation in the A and the E waves can be a indicator variation in the E and the A waves. I'll come to it later on. I'll explain it a little more. Can be an indicator of the tamponade physiology. Now, so this is the ultrasound image of the RA diastolic collapse that I mentioned. Sorry, the RA systolic collapse that I mentioned earlier. So what we are seeing is during systole, the right atrium is collapsing. We are seeing here that there is fluid in the pericardial space. So this is the subxiphoid view, and this is the collapse of the right ventricle. This is again part of the tamponade physiology, which is preventing the RV from filling. So this results in a decreased right ventricular volume and thus decrease in the eventual stroke volume. So here we are seeing that this is the pericardial tamponade here in these areas, and that's the collapse. Now, what I mentioned earlier, that is the flow across the mitral valve. then as well as the tricuspid valve, both can be assessed. So what is done is that we put a Doppler across the valve, just a little above the leaflet, and what we see, and we ask the patient to take a deep breath if the patient is awake, and what we see is that there is a variation in the size of the E wave. So if you are already familiar with the Doppler waveforms across the mitral valve, we know there is the E wave and the A wave. The E wave represents passive atrial filling, and the A wave represents the active atrial contraction. So the E wave, what we see, the same E wave within inspiration is smaller, and in expiration it is larger. So this is, if you think about it, an extension of the same pulsus paradoxes that we talk about clinically, right? In inspiration pulsus paradoxes, what happens? Blood pressure falls in inspiration much more. The drop is a lot more exacerbated as a part of cardiac tamponade itself. And here the echo is telling you the exact same thing. The flow across the mitral valve is much, much lesser during inspiration because there's an exaggerated drop in the venous return as well as the cardiac output that occurs during inspiration. The same thing can also be done across the tricuspid valve. Now, coming to treatment, oxygen, volume resuscitation, important aspects, and of course, pericardiocentesis. Pericardiocentesis can be done in three approaches. There's a parasternal approach, a subxiphoid approach, and the apical approach. Now, one thing that is very commonly discussed, especially in the context of a tamponade, is a resuscitative thoracotomy. Patient, a lot of times, who has suffered a cardiac tamponade may arrive in cardiac arrest. However, evidence has shown that the resuscitative thoracotomy is much more useful in penetrating trauma than blunt trauma. I'll come to that in subsequent slides. But this is definitely one of the, if a significant tamponade is definitely indication for a thoracotomy in the OR, if possible, if you're able to shift the patient to the OR and the patient is unstable, you've done a centesis but not stabilizing, you can immediately shift the patient to the OR for a definitive procedure. So what are the other indications I'll just cover for a thoracotomy? A type A aortic dissection, myocardial field wall rupture, especially if there's a pericardial clot, the patient has had some recent surgery, failure or inability to achieve non-operative drainage, and persistent hypotension. So these are some of the indications for thoracotomy in the OR. Now, a little bit about resuscitative thoracotomy. Now, what are the goals? There are certain specific goals that we have in mind when we talk about resuscitative thoracotomy. Here, it's basically, when we say resuscitative thoracotomy, it's basically a left-sided clamshell thoracotomy that happens in the OR, that happens in the emergency itself. You need people who are trained in this procedure to be able to do it. The goals include hemorrhage control. If there is a cardiac tamponade, to release the tamponade, open cardiac massage can be done. To prevent air embolism by closing any large vascular injuries can be closed, and air embolism can be prevented. To expose the descending aorta for thoracic aorta cross clamping. Repair any cardiac injury, especially pulmonary hilar injuries also can be repaired. And internal defibrillation if the patient is in VF arrest. So these are the common goals that we see. But when do we do it? The evidence, as I said, is greater for penetrating trauma. Some is reported as much as 40% survival. However, blunt trauma, much lesser. I think 2% is what was quoted, especially post-cardiac arrest, blunt trauma, the survival can be almost as less as 2%. So it may not be very useful in a blunt trauma. So especially if the CPR has gone on for more than 10 minutes in blunt trauma or more than 15 minutes in penetrating trauma, it is not recommended. So the cutoff time is 10 minutes for blunt trauma of CPR and 15 minutes for penetrating trauma of CPR. Right? And of course, tamponade on EFAST is another reason when resuscitative thoracotomy can be performed if the patient is rapidly deteriorating in front of us. You don't have time to shift the patient to the OR. Now, I've covered, I think, a lot of the injuries that the patient comes with. As I said, I have not covered a few things such as vascular injuries because that would be quite extensive. I just want to so more when we talk about chest trauma, a lot of times the focus is always on the initial phase, as I mentioned, stabilizing the patient, stopping the bleeding, then getting a definitive treatment done. But in the ICU, we actually face a lot of things after that. After all that first 3-4 days of surgeries, what we end up with are infectious complications. A lot of necrotizing pneumonias can happen, empyema, and especially this could happen if there's a penetrating trauma and the wound was not very clean to begin with. We may end up with anaerobic infections also in the lung. So antibiotics form a mainstay of treatment here, especially if there's penetrating trauma. Post-traumatic ARDS is something all of us probably have seen. A VV ECMO can be considered if traditional ventilatory management fails, such as lung protective ventilation and so on. Embolism is another complication that is seen. Again, it's part of the whole trauma spectrum: pulmonary embolism, fat embolism, gas embolism, especially if there are large vessels which were involved. All of these can occur. Prolonged weaning is another complication that we commonly face in the ICU. We find difficulty to wean these patients. A lot of them go back and forth. A lot of them get tracheostomies, especially the ones who come with severe trauma. Now, most of them are in need for intense pulmonary rehabilitation. So these are usually the common complications during ICU stay that we see. Dr. Zahid can add some more if you would like. So to conclude, chest trauma is any other trauma, time is of the essence. Teamwork is essential. Pain management, very, very important. Sometimes we forget about it. We're focused on everything else. The patient is in pain. And POCUS is a very essential bedside tool. We do have a lot of guidelines. We do have a lot of information. But as Dr. Zahid very rightly said in the beginning, even though everything is there, we don't have properly trained personnel in our emergency rooms. I don't think I have never seen a a resuscitative thoracotomy, at least during my short ER stints. Or I've never received a patient who has had a resuscitative thoracotomy. So for me, it's a lot that aspect is still theoretical. So anyway, that would conclude my talk, and open the floor for discussion with Dr. Zahid. He would probably be able to tell us a lot more because AIMS is a apex trauma center. So he would be able to probably tell us a lot more. You're muted.
I'm saying, ma'am, you already have covered excellently all the things that we need to, know about this. And bringing in the name of AIMS already brings a lot of pressure into it. So I also haven't seen ever resuscitative thoracotomy ever. It's theoretical to me also. So because ordinarily it should be done in OR, like you have resuscitative hysterotomy, that's also not there. So with us,
Yeah.
it lies theoretical. So there are training gaps, there are gaps in execution. That's what we're trying to overcome. So I wanted to have your thoughts about, ma'am, if we have some major, for example, airway injury, say tracheal transection or something, can we try awake ECMO before even intubating, or can there be such situations?
I mean, sure. If you have the facility, then awake ECMO is definitely an option. But a tracheal, I haven't seen such a severe injury, but that would definitely be one option. I would say the first thing, the only thing you would do in such a situation is probably just take the patient to OT, put the patient on bypass. Even if you're
Bypass.
not, even if you don't have ECMO, because you know that you need to explore, you know that you need to repair, you can just wheel the patient to OT and put the patient on bypass immediately. So I would say that itself would solve the problem. But if you have the facility to initiate an awake ECMO, definitely.
One more thing I had seen, like during my training, like 3, 4 years back before COVID, I saw many a times they would give fibrinolytics through drains. There were
Yes,
trials, I
yes,
think Misty 1, 2 or something. But
yes,
now when we go through that WSES document, they now say that they have used the language like that it increases complications, it increases cost. Like it is sort of going down as if.
yes,
So enthusiasm has somehow got down with retained hemothorax.
yes. So as I said,
At your center, do you, ma'am, use it like
yeah,
in the
we
real
do use,
world?
so actually more than us, the pulmonologist has a tendency, to use or recommend intrathoracic streptokinase. They use it a lot
I
more
think
than
I
we
think
do.
for
We
uh,
have
for
done it for a few of
pythor
the patients.
for
Sorry?
pyothorax it is in a different way than in trauma hemothorax.
Yeah,
There
yeah,
it may
that's true.
have better role here.
True, true. Yeah, because the streptokinase would definitely be more useful in a hemothorax than a pyothorax. But as I said, we have done it in a few patients. But I mean, at least what the recommendations are saying is that VATS is better than streptokinase. But if your
You
patient
already
is
said like yes, when
Yeah,
it's
if a
not
patient is too
available
sick,
and
too
they're
frail, you can't shift, then go ahead and give the streptokinase rather than leave the hemothorax in place. It'll become an ARDS for infection eventually. So better to use the streptokinase at that point in time.
Oh, I was thinking that our tendency to put needle to, remain that to take out that what you can say this your if
Like
you
little
have
bit of remaining blood,
what yeah
the little bit
no
of
no
remaining fluid.
I was thinking that in trauma, if we have tamponade, we have tendency to put needles. But if we see
Yes,
Western
yes,
literature, they have more aggression towards opening it up and doing
yes,
thoracotomies and checking everything right in front of
yes,
eyes or doing riboa and other things. Are you
yes.
using in your center in South? Do you guys use
Riboa?
riboa?
No, I
Um,
mean Riboa I haven't seen. Again, this is something that is quite theoretical only. And what I was reading is that it is less, it's more in abdominal trauma when the abdominal aorta is involved. Thoracic aortic injuries, also it can be used, but again, the distance is a lot more, no? So, but abdominal aortic injuries, the use is much more, describe a bit better. But no, the Riboa even I haven't come across.
There are a lot of strange things I see that you have to twist lung if there is hilum air. So just to feel that it seems very scary. So
Yes,
let us
yes.
stick to basics at the end of
Yeah,
it. It
yeah.
was an excellent session,
Thank
particularly for myself. It was great learning to go through all this. You answered every query, and
you.
I think we had some trouble with letting people, join it in the real time. Anyways,
Oh,
it will be on YouTube and it will be on different forums from
sure.
Young India Intensivist. Thank you very much, ma'am.
Thank you so
I
much.
think here we should stop, and it's
Yes.
already. Thank you very much.
Thank you.
Thank
Thank
you,
you so
ma'am.
much. Dr. Zahid, it was
Thank you,
lovely
ma'am.
talking to you. And thank you
Thank you,
for the
ma'am.
opportunity.
Thank you, ma'am.